All right, I'll maybe get started while we fix the presentation, and hopefully the slides will catch up with me. Today, I want to talk about affordability of scaling HIV treatment and care, and can we afford to do test and treat. And given that I think most of the people in the room that I'm talking to agree that test and treat is the right approach to care, why is it that we're still having debates about this, and how can we change the discussions? I'm going to focus on opportunities to optimize and invest in optimal delivery and regimens, and I'm going to wind up on drugs, which is my particular background area. I think if we had slides up right now, you'd see a very familiar one, which shows number of patients who were previously eligible for treatment under the 2010 treatment guidelines, and the numbers of new patients who are eligible under the 2013 guidelines, which takes us from a total patient population of around 16 million to around 26 million. And I think this is a very exciting change to the treatment guidelines, and thank you. On the far right, of course, we have the estimate for total number of people living with infection at 35 million. I want to say a few things about this, because I know we all see this slide quite a bit. First of all, the decision to go from a policy where 16 million patients are eligible to 26 million or even 35 million patients are eligible is an intimidating decision for donors and local governments who are not sure if they're going to be able to afford the lifelong commitment they're making when they make those changes. And so what we found to be really important is to understand what the real costs of treatment and care are, and help countries understand what resources they currently have and can expect in the future, so they can make good decisions about treatment eligibility. And I think we found that in a number of countries in which we work, after you do that analysis, then programs are very willing to increase patient eligibility and expand the scope of their guidelines to include more patients. Now, obviously, despite all of these guideline changes, we still have a long way to go from the 10 or 12 million patients we have on treatment today to the ultimately 25 to 35 million patients that we'll have on treatment at some date in the future. We're going to come back to this, but I want us to jump into the future for a minute and think about an end state where we have 25 or 35 million patients on treatment, and do a lot of thinking about two scenarios. One where we have a very high attrition rate to patients in care, similar to what we see in programs now, and one where we invest in better retention and adherence to treatment, and reduce that attrition rate going forward, and thinking about what value that brings that we need to invest as a community. So the second slide, which I think is probably familiar to all of you in one form or another, is that resources are not an endless commodity, and in fact we're at a point where a lot of the new resources coming to the fight against HIV and AIDS are coming from local governments and private donors. And again, this brings us back to the import of making sure that decision makers understand the budgetary consequences of program decisions they're making, so they can make those decisions with confidence and go forward. Because I think what we found is that a bigger impediment is not what programs will actually cost, but not knowing what they might cost and the fear of the unknown. And once you start answering some of these questions very practically, programs are willing to go forward and scale up. Okay, so CHI does a number of things in this area, but one of the things we undertook in 2010 and 2011 was a large study called MATCH to understand what the cost of delivering care to patients is. There are a lot of big caveats to this study, the biggest one being that these are the in-facility costs. This is not looking at all of the systems costs that go beyond the in-care, the in-facility costs. But what I think this study did show us is that programs in low and middle income countries are delivering quality care at a cost of around $200 to $300 per patient per year. And if you you essentially take this and you correct it to optimize those programs to incorporate the 2013 guidelines, you're still looking at a cost of care in the range of $250 to $500 per patient. If you start doing the multiplication, that means that given the funding that's available now for HIV treatment, we can afford to get to a universal coverage model if we use our funding wisely. So the next point I want to make is that given that we've now measured the cost of delivering care, I think we have to remind ourselves that that cost is not going to remain static for a number of reasons. Number one, we're looking at bringing patients into the treatment system who have a different background and profile to patients we already have. And that means a greater number of healthier asymptomatic patients for whom the cost of care may be lower, but we may need to spend more on retention and care and adherence in order to make sure we keep them in care. And as we get better at our diagnostics and patient monitoring, we're going to have an increase in volume complex patients, for example, patients requiring second and X-line treatment and pediatric patients. I think offsetting that, what we've seen is that programs very rapidly adapt and optimize their models, and we can expect that to continue over time. So I think we have to expect that work on decentralization, wisely using the mix of healthcare workers that we have available to us, are going to lead to further optimization of care and delivery. And finally, coming to an area that I like to spend a lot of time on, which is the commodities. I think the commodity costs may come down over time. We may need to use a bit more on the testing side, so that's going to put upward pressure on prices. And the price of drugs aren't going to come down forever. But I think 2 points. Number one, if you look at spending on HIV care right now, only about less than 10% of HIV treatment dollars go to the actual commodity cost for treating HIV. So this is not actually a huge component of that $16 or $18 billion spending figure that we often hear. And secondly, I think we need to think about some of the programmatic value that these products bring in areas outside of the commodity costs. And I'll elaborate on that in a couple of minutes. Okay, so I think, in going back to one of the points I made at the beginning about why are we having such a debate with the world at large about whether to do treatment as prevention when, most of us in the room agree that this is the right thing to do and a good thing to do. And I want to try to reframe that by asking a few questions that are similar to the ones that are asked today, but maybe not quite the same. And the first is, can we afford not to treat the patients that we diagnose, as opposed to questioning whether we can afford test and treat? And, I think if you look at a lot of the modeling and arguments about whether we can afford HIV treatment, a lot of the time we're not looking at a fully balanced equation. And what I mean by that is I think we're frequently not accurately measuring the cost to the non-HIV healthcare system that results from HIV patients who are not adequately and appropriately treated and have their infections under control. Secondly, we spend a pretty large amount on pre-ART programs relative to treatment programs. Not a lot is known about the attrition rates in these programs, but it seems likely that we're probably losing quite a number of patients that we then have to pay to re-diagnose and re-enter into care. This also means that it's more expensive to treat your patients when they start because they're sicker. I think you can make all of these arguments from the patient-centric perspective and say, the benefits to patients to starting treatment in care are significant. And if we're messaging well, then, I think from the patient perspective, there's also a compelling argument to start care early. If you initiate earlier, you need to consider some of the savings, not just within the HIV cost sector, but in terms of reducing the cost of treating OIs and the lowering the burden on the healthcare system outside of the HIV-focused healthcare system in countries, and lowering the cost of treating patients because those patients are going to be healthier. Okay, so the second question I want to ask is, can we optimize and almost commoditize retention and care and adherence to care? And I want to come back to the question I asked at the beginning, which is, if we get to the point where we have 25 or 35 million patients on care, there are two very different scenarios you could see where we achieve the same result. One where we have a very high attrition rate, and we have to spend a lot of money going out and refinding patients who've been lost to follow-up and reinitiating them on treatment. Their care will be of a higher cost because their health outcomes will be poorer. Or a scenario where we focus and invest in improving adherence and retention and care, and we have to spend less money on case finding and more complex cases because we have healthier patients overall. And I think we used the example of Malawi to show that improvements in retention have benefits not only to reducing number of new infections that you have at the community level, but also actually reducing the overall cost of your healthcare system overall. And if you look at the difference in cost that you're spending in those two scenarios, I would argue that that's the value that we should be looking to spend on retention and adherence interventions so that we get better outcome at an equivalent cost. I honestly think that as we look 5 to 10 years out, whereas the discussions 5 years ago were on cost reductions of commodities as the major source of savings and efficiencies in HIV treatment, I think that one of the key focal areas in the future 5 to 10 years is going to be on improving loss to follow-up and retention and care. Okay, so there's a lot of big question marks about how you do that programmatically, but I want to take this opportunity to shift and talk a little bit about drugs and commodities and how they can contribute to that solution. And so in an environment where drug costs are coming to a point where they're going to reach their minimum, the question I want to ask is there still benefit to investing in optimized treatment regimens and making sure that patients are getting better and better optimized treatments? And I would argue that if you look at the cost to poor retention and adherence to treatment, as long as commodities and the drug regimens that we're looking at can help be part of the solution to keeping patients in care and adhering to their regimens, it's worth the investment even if it's a cost-neutral change. I want to highlight a few key drugs in the development pipeline which represent optimized versions of drugs that we have available to us, or new drugs which present the opportunity to incrementally improve healthcare for patients, either on the cost front or through improving retention and care. And I want to highlight a particular category of drug. We've seen a notable result recently with the recently FDA-approved dolutegravir, where studies showed that there was actual superior efficacy, which, if you look at the data, results primarily from patients staying on their treatment in greater numbers because side effects are lower with that drug. There are a number of opportunities in the pipeline outside of dolutegravir that also represent similar opportunities. And those include dose optimizations on protease inhibitors, which are particularly difficult to tolerate. Lowering the dose of efavirenz, which has been shown to statistically reduce the number of CNS side effects, and we're waiting on the 2-year results of that study to see if that translates into a superior result or not. And a number of other drugs in the pipeline. So I think one of the key points I want to make is that we need to look at drug optimization opportunities not just in the context of cost reductions going forward, although we'll still see some reductions in drug cost, but also looking at how those improvements actually reduce the cost of other systemic costs to delivering treatment on a large scale. And we've got a long way to go on this. I think we have decent retention numbers on first-line regimens. At CHI, we spent quite a bit of time focused on scaling up second-line treatment, where if you look at the numbers right now, they're absolutely abysmal. And most patients who start a second-line PI-based regimen are no longer on treatment after 2 years. So we have a pretty low bar from which to work in terms of improving treatment for patients who require second and nth line care. So to wrap up, I think we believe that scale up to very high levels of coverage is affordable as long as we spend funding wisely. The incremental cost is not necessarily fixed based on what we're currently paying to treat patients, because the patient populations are going to change over time, and a significant investment in retention, keeping patients retained in care, I think is going to have a very large benefit to programs going forward. Thank you.